So welcome everybody, good evening. Welcome to tonight's leadership webinar on being an ambassador for cultural change and challenging the status quo, and particularly in practice. I know this is an area that many of you have felt that you've struggled with. You're often taught to be leaders and trying to ensure best practice on placement, but actually taking that leap in challenging the status quo can be incredibly difficult. And I think nobody knows that better than Helené Donnelly OBE, who many of you will know was critical in exposing the failings at mid-staffs. Since then, Helené developed the role of Ambassador for Cultural Change and works closely with the National Guardian's Office and their Freedom to Speak Up Guardians that some of you will have heard about in the conference in November. I'm sure Helené will go into more detail on this about her background and experience. So I'm not going to talk for ages, but Helené, welcome and thank you for taking time out to be with us this evening, and we're delighted to have you. I'm hoping she's not frozen because she looks like she might.
So I'm Helené Donnelly. I am an ambassador for cultural change across the NHS, and I also work as a lead Freedom Speak Up Guardian at Midlands Partnership Foundation Trust. So I'm going to talk a little bit today about my own personal experience, professional experience. I've got some slides to share, but hopefully they won't be too boring. We won't dwell on those too much, but hopefully it's helpful. And Nellie's going to help me with those when it comes to that. And then hopefully we'll open it up to some Q&A and you know, kind of want to hear from you. So hopefully we won't have any more technical problems. And just to let you know as well, I've got 3 kids who should be going to bed, but if one of them wanders in, you know, I'm sure you all know what it's like, particularly at the moment with how we're all trying to work. So my background is that I'm a nurse and particularly specialised in emergency critical care, and I worked and trained in a variety of settings in a big city teaching hospital. But then when I qualified, because it was close to home, I took a newly qualified post in a sort of district general hospital, quite large, and you'll know it because it was called Mid-Staffs Hospital. And I was there for about 6 years in total, I think. And as I say, took a position as a newly qualified on a rotation. And that was great because it gave me a critical care rotation, an emergency care rotation, which is what I wanted to do, and worked in numerous different wards, including ITU, and ultimately in A&E. And about 2 years into qualifying, that is when I took a permanent position in the accident emergency department. And almost immediately, I could see that there were problems within that department. These varied from general attitudes of some of the staff, although they were in the minority, but some were in quite senior positions of power, so they had quite a wide influence. But there was a lack of staff, both in terms of nursing and medical staff. And there was a huge lack of equipment. So serious equipment like cardiac monitors, like giving sets, IVAC pumps for intravenous infusions and so on. But also the basics like blankets, pillows, simple things to keep patients relatively comfortable and have some dignity, really. And then there were other issues as well. So lack of training, lack of development opportunities. These would all be pulled because of cuts with funding or because we didn't have enough staffing to be able to go and do that. There was not proper preceptorships for people who were newly qualified or new to the department. And there was a very much an attitude of just kind of get on with it, or, you know, this is how it is, we've all got to get on with it. And I think for the most part, people want to do that. You know, everybody's there to sort of try and pull together to be a team player. But obviously, when you can see that there are significant problems, that obviously wears you down. And particularly if it's day in, day out, if these things are a problem just for a short term, people can get on with it and we can support each other through it. But I think when it becomes, you know, every day, it as I say, it wears people down. So as a relatively newly qualified member of the team, but certainly somebody who was new to the department and to the team, I found it really difficult to speak up about any of these things because I thought I was new, again, relatively newly qualified. So kind of what do I know and who am I to question the status quo? But it became so obvious that these things were really causing detrimental impact on patient care, quality, safety, but actually also on the well-being and the morale of staff as well. And I was not on my own in my thinking. So it soon became very clear that a lot of other colleagues, nursing, medical, allied health professionals, felt the same. But there was either a sort of degree of apathy in that, oh, this is how it's always been, nobody ever listens, nobody does anything, nothing ever changes, so there's no point in saying anything. Or people would just leave, and people were always looking to move on or to get jobs elsewhere. So, you know, really valued members of the team, really experienced, qualified, wonderful clinicians, practitioners would leave us and move elsewhere, which then just kind of exacerbated the problems really that we had. So there was an accumulation of these things building, and I did start to raise my concerns. So initially I started to raise them verbally with senior leadership, with line managers and the ward manager. And it was just really shrugged off and dismissed, and you were just told to kind of get on with it, or as I say, this is how it's always been, this is how it is. Or there would be kind of false hope and false promises. And this would be very much tied up in the fact that the trust was striving for foundation status at that time. And so there was a real push that we had to be seen to be hitting targets in order to reach foundation status. But that once we did, because as an organisation, they would be in charge of their own finances and in theory in more control, they would be able to release funds for us to have the things we were so desperately lacking. So there was a real false promise of we'd get more staff, we wouldn't be relying so heavily on bank staff, we'd get more opportunities for development and training, et cetera, et cetera. So, you know, again, because you want to be a team player, because you want positive, because you want to feel the best of where you work, you kind of go with that for some time. But again, it became obvious that that was kind of false hope. And it also became obvious that even if that was something that was to be realised in the future, in the here and now, on a daily basis, patients were suffering. And that was something I just couldn't tolerate. There were several incidents. I mean, there's so many. I'd literally be here all night telling you about them all. And a lot of them were documented as part of what would become obviously the Francis inquiry. But some of them, for me, were a kind of turning point, I think, in that I was raising concerns. I was incident reporting through the usual incident reporting systems. And in the early days, that was a paper, handwritten incident report that we'd put on the ward manager's desk. And I was reliably informed after this that she literally used to just screw them up and put them in the waste paper basket. But even latterly, when it became uploaded into the intranet and you'd sign it and it would click the incident form, you'd say you'd want to have some feedback and it would go off into the safeguard system. Again, there was just this kind of radio silence. We didn't hear anything back. We didn't get a thank you. We didn't get any feedback. So you just think, you know, what's the point? And that was particularly difficult as well because, as I'm sure a lot of you are aware, it's quite time consuming writing incident reports sometimes. And, you know, you'd be staying behind after your shift or going in early, and you were literally doing it on a daily basis. So again, it became something that was a problem in itself, even to try and do these things, particularly if you felt that you were not being listened to. So there were a couple of incidents where I felt I had to do more. And one of them was when I was working in the resus area of the A&E department, and there was a relatively junior doctor. He was on a rotation. He hadn't been with us for very long, and he came to ask me to help assist him with a patient. And this patient was in a wheelchair, and she was queuing down the corridor along with many other patients because we were so short on space and so on to get patients into the department. And she'd been there for a little while. The doctor had called her, but she was obviously in a wheelchair and he needed help getting her up onto the trolley. She'd come in with abdominal pain, so he wanted to do an abdo exam, fine. So I went through, and although I wasn't working in that area, he couldn't find anybody else to help him. So I sort of quickly went through and went in to see this patient, tried to help her up. She was in her 70s, but, you know, quite fit and healthy. And just really struggling to get off the wheelchair and was feeling quite weak at this point. So we tried to get her up on the trolley, couldn't do it. So I went to get some assistance, and I went to find one of the sisters who was in charge of the department. And there were two particular sisters who were often in charge, who were what I would describe as the perpetrators of really poor behaviour and conduct towards each other, rude comments made to each other about staff's weight, about staff's mental health issues or problems, about relationship problems that people may be having, about staff's competencies and so on, and really nasty derogatory comments made. But even more concerning, they'd make comments of a racist nature about both patients and staff. And they'd, you know, do this in earshot of even patients. Again, you know, just have curtains dividing cubicles, and patients and relatives could hear what was being said. Really bad language often being used as well. And again, you know, there is a bit of gallows humour in A&E, and language can be quite blue sometimes, but again, not just routinely, and not certainly in earshot of patients and relatives. It just is, for me, that just isn't acceptable. But they would do this frequently and really belittle staff, and basically it was their way or the highway. And they would intimidate and manipulate people into doing what they wanted because they were in charge. They also used the fact that they would run the rota system. So again, if you didn't do what they say and comply with them, they would say things like, oh, you want that Saturday off, or you want that night off, well, you can forget it, and those kind of things. Or you want that week off annual leave, no, you're not getting it now. You know, really vindictive, manipulative stuff. And they would also put people forward for training opportunities. Not that we had many, as I said, but if there were any, if you were in their clique, you would get put forward for those. If you were not, you would not. So they use that as a kind of power control. They also frequently falsified the 4-hour breach time targets, and they would pressure doctors and nurse practitioners into discharging patients before they felt able to do so, so that the patient didn't breach that 4-hour target. And the reason they do this was because they were bullied and pressured themselves actually into doing this, albeit not directly and not formally. But if they had so many breaches, they would have to go up the next day to a bed management meeting and justify and explain why they'd had these. So, you know, they were really bullied and victimized themselves actually. But then they would, you know, kind of perpetuate the behavior and the culture by then passing that on to staff and colleagues within the department. So this was what was really happening in this instance on this particular day. So I went to find this nurse, who was the only one I could find for some help and assistance with this patient. And she kind of reluctantly came with me, pulled the cubicle curtain back. And as soon as she saw the patient sitting in a wheelchair, she took one look at her and said, oh, turned to the doctor and said, you don't need to see this patient, just get her out of here. She's a waste of time. She was in here yesterday. She's a naughty little monkey and she's not taking her laxatives. That's why she's got up to pain. Just get her out because we need the space. And she kind of flounced out and left. The patient obviously became distressed at this. So I knelt down and talked to her, and she explained that she had been in the department the day before. And what had happened was that she had, until very recently, like literally within weeks, been fully independent, fit and healthy, living on her own. And then she'd suddenly started to deteriorate and have some ailments and problems and become a little bit unsteady on her feet. And because she didn't have any friends or relatives nearby, she'd been persuaded to go into a nursing home for just some respite care. But really, she was still managing on her own. But in the last few days, she'd had increasing difficulties with some shortness of breath and some abdominal pain. And she had been in the day before, and they had said that she'd got constipation and they had prescribed laxatives. But she got very distressed at this and explained that she'd not been taking her laxatives because she'd become so unsteady on her legs. She was so afraid of not being able to get up and get to the toilet on time and soiling herself. So I completely understood this, tried to reassure her as best I could, and then said, well, look, let's try and get you up again, and so the doctor can examine you fully. But with that, we had a standby call. And as I've said, I was in recess. So I really shouldn't have been in this bit of the department anyway. So I had to bow out and said, I'm really sorry. I'll see if I can find somebody else to come and help you. I'm going to have to go. So on my way rushing back to resus, I did find a healthcare support worker and said, could you go to cubicle, whatever, and help the doctor, which they said they would do. So I was then caught up in resus for quite some time. And then some hours later, was walking past a sort of makeshift waiting area, and saw this patient sitting in her wheelchair still. And at this point, she was vomiting into a vomit bowl. So I went to check if she was okay. And she said that she was waiting for transport back to the nursing home. The doctor had discharged her. So I went to find the doctor and said, you know, what's happened with that lady? Because I've just seen her and she's now vomiting as well. Did you do an abdo exam on what was the outcome? And he said, no, I didn't do an abdo exam because we couldn't get her out of the chair. And the sister in charge told me to discharge her and get on with it because they needed the space. So that's what I've done. And I said, well, I think you really need to see her again. She's now vomiting. She's obviously deteriorating. And he said, no, I can't. She's been discharged. And obviously the sister won't allow it. And he'd got a pile of other CAS cards to get through and moved on to the next patient. I think at that point got called back into resus, and that was the last I saw of it. So the next day I was on duty again on an early shift, and about 10 o'clock in the morning I was in resus again, and we had another standby call. And at this point the patient comes back in. This point she's lying on a stretcher with paramedics bringing her in, obviously standby, and she's in and out of consciousness at this point. She recognises me and takes my hand and says, am I going to die? And I tried to reassure her as best I could. And she did lose consciousness, and sometime later she did die. I later found out that she had obviously not been seen by the doctor and he had discharged her. And she'd actually sat in that waiting room. I'd seen her about 6 p.m. in the evening, and she had remained there till 1 o'clock in the morning, waiting for transport back to her nursing home on her own all night, in pain, vomiting, afraid. And she'd obviously come back in the next day, deteriorated and died. A post-mortem transpired that actually an abdo exam might not have changed the outcome, and it may not have prevented her death. However, my, concern and, overwhelming worry about that whole experience was not just that she happened to die, but that her last 24 hours of life were such that she didn't receive the care and compassion and dignity that she should have had. And I think that's appalling. And that was one of the many turning points for me where I felt I have to do more. So I did, and I started writing much more formal statements around the bullying, the dismissive attitude in the department, the whole catalogue of concerns that many of us had around how we were all treated, the pressure to falsify breach times, to discharge patients before they'd been adequately seen or before we'd had adequate examinations and tests results and so on back. And I was relatively surprised where we had quite a good response actually from some of the senior leadership who seemed to act upon it. And one of the sisters was removed from the department pending an investigation. But the investigating officer who was tasked with the investigation was good friends with this sister, and we all knew this, so it didn't feel appropriate. And bullying increased in the department because of this, because obviously she had a little clique of friends, and there was another sister as well who was good friends with her, and they started threatening me and colleagues who supported me. I was threatened about walking to my car at night. I was locked in a changing cubicle and threatened. So, it was real intimidation. The investigation went on. The second sister was also suspended. We pushed for an external investigator to come in, which they did, but it was all ultimately hushed up and concluded without any formal feedback or outcome. And they were just brought back into the department. And coincidentally, or not so coincidentally, this was just before the then Healthcare Commission, as well as obviously now the CQC, were due to come in to do an inspection. And we were all told we were not allowed to speak about it. We were not allowed to talk about what had gone on. And it was basically all hushed up and swept under the carpet. Threats increased for myself and colleagues who'd supported me, so physical threats, but also of a professional nature. So things like checking controlled drugs. I was warned not to check controlled drugs with certain people because they were going to make it look like I made a drug error, which again, as I'm sure you can appreciate, you don't always have that luxury. So, you know, it was really intimidating going into shift every day, constantly afraid of my PIN number being taken away because of something they were going to effectively stitch me up for. So for me, my position became untenable, and I had to leave and move to a neighbouring trust where I was able to sort of move on, I think, from this. But I was always still concerned about patients and colleagues who remained there. So I continued and I pushed, and ultimately, having spoken to MPs and campaign groups and so on and so forth, ended up giving evidence at the Francis inquiries, both an independent and then the public, and ultimately also an NMC hearing, which saw the two sisters I've spoken about being struck off the register, which was very sad, and it shouldn't have necessarily had to come to that, but because they just refused to show any insight, any acknowledgement for anything they'd done, the NMC really were left with no alternative. But it was also found out through this that the trust had struck up a deal with the union supporting the sisters, that if they were not reinstated back into the department prior to the Healthcare Commission coming in, that they would take out sort of counter allegations and complaints against the trust that they themselves were being bullied, which, as I've said, in fairness, they were. And that's why it was hushed up and no formal conclusion ever came forward. So I know just how difficult it is to raise concerns. And because of that, when I then went to work in the trust I went to next, and through my whole experience involved in the Francis inquiry, the NMC hearings and so on, I thought we need to do more. We need to change cultures. We need to really drive better compassionate leadership across the NHS. And when I say leadership, I don't just mean those in designated leadership roles. I mean all of us. We're all leaders in whatever it is we want to drive and make the change in. And so I created, with the support of my then CEO, the Ambassador for Cultural Change role, which then expanded and ultimately became the Freedom Speak Up Guardian role. And this role was created really to give an additional route for staff to speak up and raise concerns to somebody who can act effectively in an independent and impartial manner, but crucially can make sure that concerns are heard at the highest level. So we created it that I reported directly into the CEO, directly into the leadership, senior executive leadership team, had access to the chairman, to non-executive directors. And also there was the understanding that should I ever need to, hopefully I wouldn't, but should I ever need to, I would go outside of the organisation to the CQC, to NHSI, etc., so that we can really break down the barriers that exist and really open up some transparency about some of the real challenges we face out there as clinicians and practitioners. And this role took off, I'm pleased to say, and we had lots of interest from other organisations, and we supported them to develop similar roles. And ultimately, I ended up lobbying everybody and anybody, including the Prime Minister at the time, and we ended up with the Francis Review in 2015, which I can talk a little bit more about, but I think some of you are already aware, because this then ultimately resulted in us creating the National Guardian Office, and the Freedom Speak Up Guardian role then was spread across the country, and it became part of the NHS Constitution that every trust would develop a Guardian role, which we now have, and it's fantastic, and obviously I still act in that capacity. And it's just so important that we have this role out there now to really hopefully encourage and enable people to speak up. We don't want them to necessarily have to come via a guardian to do it, but we want them to know that we're there should they need to, even if it's just as a sounding board for somebody to talk to. So it's a bit of a whistle-stop tour of my own personal experience, but hopefully it just gives you a little bit of flavour and insight into kind of where I've got to with all of this. But even now still, you know, over 10 years on, I see echoes and examples of what I experienced with mid-staff still happening across the NHS, and particularly in relation to bullying, to negative behaviours. Some of it's just sort of passive aggressive stuff. Some of it's probably people who don't even really realise that's how they're coming across and how they're behaving. Some of it's driven by pressure, particularly at the moment. Everybody is so chronically overwhelmed. COVID has just come at a time when the NHS is already on its knees, not just because of winter pressure, but just because of a huge lack of funding and real resourcing. And so to see how the NHS is responding in its fight against COVID is just overwhelmingly amazing. But I do have to ask the question, you know, how are we going to survive going on from this? Because I do think there is some real issues around leadership, around behaviours, and around the general culture in the NHS. And this is what was picked up at mid-staffs. And although there have been huge strides forward, and we talk about this stuff a lot more than we ever did before, but we're still seeing so many examples of it still existing that worry me. And for me, in order to really change culture going forwards, we need to engage with you guys as students, as newly qualified staff and colleagues. You are going to be the ones who can change the culture. You are going to be the ones who can go out in real time and really show the way, lead the way, and show how it can be done. And that's, for me, where my passion now lies, because it's around supporting students and newly qualified to really feel empowered to go out there and galvanised, I suppose, to go out there and make that change. So with that, if Nadia, if you can help just click on to the first slides, that would be really helpful, and I can talk through.
You can't see it, can you?
No, sorry.
Oh.
It's not come up.
There it is. Now?
Oh yes, well done. Thank you. So yeah, if you click on to the next one for me, thank you so much. So this slide really just demonstrates for me how it's really difficult thing to do to sort of challenge that status quo when you, particularly as a student or as a newly qualified, but as anybody really, because you're going to be that one usually to take that leap of faith and go for it, and it's a really brave thing to do. You'll often find that after you've jumped, other people will follow, and that's certainly what happened to me. So I had loads of support after I did it, but I was the first person to do it, although people had already frequently written incident reports and so on. But as I said, they seem to just sort of go into some sort of black hole. But to do it sort of formally as I did and keep pushing, I was not on my own. I was supported by other nurses, other allied health professionals, even receptionists, cleaners came forward to support me. So, you know, it can feel a very lonely place, but actually, if you take that leap, others will often follow. But I think we all have to acknowledge just how scary it can be. And I think there's sometimes a bit of a complacency out there about, actually, you know, we all know as part of our code of conduct that we should do this and we should raise concerns if we have them. But knowing and doing are two very different things. And it's actually often only when you do it that you realise just how daunting it is and where the barriers are and how you feel that you're very on your own. So I think it's really important for us all to acknowledge and how everybody can be in different places and people have different personal experiences and different personal responsibilities. And it's not an easy thing to do, and we have to understand that. Next slide, please. So again, clearly I've talked about my experience at mid-staffs, but there's other images here that demonstrate some of the worst scandals to hit our NHS and social care system over years. Obviously, we know at the moment in Shrewsbury and Telford hospitals, there's issues around maternity, and that was what was seen at Morecambe Bay as well. Again, if any of you are aware of James Tidcombe, who has campaigned, he lost his son at Morecambe Bay, and he has campaigned tirelessly and still works now supporting patient safety issues. He's written a book as well. So again, if any of you are interested in reading that, it's a really interesting story. And he works really tirelessly to raise awareness about it as well. So again, the echoes from Morecambe Bay we're now seeing coming out at Shrewsbury and Telford. And again, there's this complacency people say it to me now about how mid-staffs was a one-off, and I mean, maybe in the extremities of it, you know, how extreme it was and how it was such a perfect storm, maybe it was, but I have always said, and will continue to say, that certainly elements of it and pockets of it are still happening up and down the country now. So maybe in its extreme, yes, it was potentially a one-off, but there are so many things that are still happening, and we have to always be aware of that. Gosport as well, huge issues there. Winterbourne View, horrendous care that only came out via Panorama, and somebody having to take that step to go to the media to get their story heard. Clearly horrible shipment, and then there's the reference to Jimmy Savile there as well, and obviously that's in relation in the NHS into his experiences at Stoke Mandeville, where we know that nurses had concerns, but they will not listen to. People told them to be quiet when they were trying to raise their concerns because of who he was. So again, it is really important that we listen to each other. Next slide, please. And this is important why we listen, because, you know, we have to pay attention to those little whispers, those little things, those little niggles, those little things where people think, oh, I haven't really got evidence, or I'm not sure. Sometimes it's a gut instinct, sometimes it's just soft intelligence, but people start having concerns often before any significant damage is done. And if we listen to people and crucially then acted upon it, just think of the horrific harm that could be avoided. So it's really important that we enable each other to do that, and we lead the way in making sure that people can speak up and they are listened to and they are heard when they do. Next slide, thank you. So this is sort of a demonstration again. I think I've touched on it just a little while ago around, you know, why we do what we do. So we all should be aware of our code of conduct. And I think this, for me, came out, one of the questions Robert Francis actually asked me when I was giving evidence at the independent inquiry was, why did I do what I did? Was it because of my awareness of my professional code, or was it something else? And I hadn't really thought about it, in all honesty, until that point. And I thought, well, of course I was aware of my professional duty and my professional code, but for me, certainly sitting alongside that, or possibly even more, was, for me, it was more a moral code and an ethical code of this isn't right. And for me, it was always about, what if that was my relative? What if that lady I've talked about was my grandmother, my mother? What if, you know, what if that was me? And I think that's how I've always nursed. I've always treated people as I'd want to be treated myself, or I'd want a member of my family to be treated. So I think overwhelmingly that's what drove me to do what I did. But really, it was all of these things in one. But whatever is driving you to do it, keep listening to that and don't doubt yourself, and encourage other people to do it for the right reasons as well. It's really easy to sit back and think, well, as long as I've done what I can do, as long as I've gone in and given my best on that shift and done everything I can do, then what more can I give? And I get that, because I was in that place for a long time as well. But actually, we can and should lead the way in making it better for everybody. And that's not an easy thing to do, but it's an important thing to do. And whether it's your professional code, your ethical code, your moral code, or something in between, or all of them together, don't doubt it and go with it, and explain to people that's why you're doing it, because you have a duty to do so. Next slide, thank you. So this is, I've already touched on this obviously, but this is just to reference the Freedom Speak Up review in 2015. Robert Francis actually asked me to assist him on this review, which I was glad to do. And again, that is why he had 20 recommendations, and 2 of which were that we would establish a National Guardian office, and obviously the National Guardian role, you know, help then spread the Freedom Speak Up Guardian role in each organisation. A lot of the other recommendations or principles haven't necessarily been taken up, as haven't a lot of the recommendations out of the mid-staffs inquiry. And I think this is concerning, because, you know, how many inquiries have there been previously and will still come, and they just kind of sit on shelves and gather dust, and then 5-10 years later something very similar happens again. So this is why I still talk about it. This is why I push it. This is why you guys going out there as students, as newly qualified staff, keep pushing it, keep drawing people back, not just to mid-staffs, but there's, as we've demonstrated, there's countless other horrendous scandals where this stuff has been echoed. And, you know, we've got to keep always having that at the fore of our mind in everything we do, so that we can try and prevent these things happening again. Next slide, please. Thanks, Ellie. So yeah, sorry, this is a bit, lots of info on here. And I know some of you have already heard from Henrietta Hughes. So this is just some of the stats that she may have already shared with you, to be fair. But so Henrietta was established as the National Guardian Office. The National Guardian Office was established in 2016 at the same time that the appointment of the Guardians became, the Guardian role, I should say, became part of the NHS standard contract. So just to give you some context, really, so last year there was over 16,000 cases raised to Guardians. So if you think about it in terms of the whole of the NHS, that's not many at all. It's a drop in the ocean. But if you also think about it in terms of this is still new, we're still gathering momentum on this. And as you can see there as well, that since the NGO, the National Guardian Office, started collecting data in 2017, more than 45,000 cases have been raised. So that's huge, and it's gathering year on year. But you also have to question that just for last year alone, those 16,000 cases, if there hadn't been a Guardian there, where would people have gone? You know, where would they have gone to with their concerns? So it's, you know, it's really gathering pace and momentum. And as more and more people are aware of the role and feel confident about going to their Guardian, it's having more and more of an impact. Again, just some of the stats we report on every quarter to the NGO. We report on patient safety, whether there's concerns have an element of bullying or harassment, and whether there is any detriment within that as well. And as you can see there, 23% were around patient safety, and 36% had an element of bullying and harassment, which is really quite big. And it's also echoed in the staff survey as well. So we know there's a lot to do around bullying and behaviours and conduct, which again echoes my mid-staff's experience. And also, Freedom to Speak Up was incorporated in the well-led domain of CQC inspections, which really has put it on the map, and why boards and the general workforce needs to take this seriously, because the CQC they go out, they want to speak to the Guardian whenever they're doing an inspection, and on their walkabouts they will ask staff, you know, do you know how to speak up on your organisation? Do you know who your Guardian is? So it's really important that we spread this message. And just a nod there to the fact that this is really all about compassionate leadership, because if we have compassionate leadership in place, then people will just speak up as a kind of business as usual approach, and it will prevent bullying, which ultimately stops people speaking up. And if we prevent that, we'll spread positive cultures as well. Next slide, please. Thank you. So again, I don't know if many of you are aware of Michael West. I should think you are, Professor Michael West. He's an amazing guy. If you're not aware of him, go and look him up. He's fantastic. And he's done so much across the NHS around compassionate and collective leadership. And this is just one of his quotes. There are so many I could have chosen. But this, I think, sums it up really nicely, which is compassionate and collective leadership is really just what we should all be doing anyway. But it is around having that, you know, authentic openness, curiosity, kindness, appreciation, and compassion for each other. And I think curiosity is really important as well. You know, when people are raising concerns, we need to thank them and ask them why. You know, what is it? What's sitting behind that? Ask questions, learn more, rather than being defensive and shutting it down. We need to open up those conversations, open up those dialogues. And again, this is something we can all lead the way on. Next slide, thanks, Alia. So this was just an interesting stat. Again, this is out of a kind of business model rather than NHS, rather than social care or anything like this. This is from the Harvard Business Review, but I thought it was interesting. And again, I thought it kind of echoed my experience. But 72% of leaders said they have never or rarely challenged their own status quo, and they do not encourage employees to think outside the box. And I think, again, that's interesting. Again, I'm generalizing and I'm looking at the negative. There are so many leaders out there who I know do this stuff and are really positive, but for those that don't, we need to keep pushing at that. We can't ever get complacent and ignore that, because we know that can then create and fester problems and damage ultimately to the workforce and to each other, but knocking onto that, obviously, patient care and service delivery. And it's really important that we do encourage people to think outside the box. And again, part of that is being inquisitive, like I was saying, you know, be curious, ask the questions, and encouraging our students to do that. There's such an amazing wealth of a sort of untapped resource of knowledge. You come into it with fresh eyes. You are the guys who can see when things, you know, everybody else has kind of got blinded to it because it's just become business as usual to them in a negative way. And we need to really encourage the students and newly qualified to really have a platform around each table when we're designing new things, when we're looking at new creations of services. Students, newly qualified, should be there around that table because they're such a brilliant source of information and can come from a different place and thinking outside the box, which is something I think we should all do. Next slide, thanks, Nadia. So this again taps into the compassionate, open cultures and providing better care really for our patients and service users. But I just always say that if we do not look after each other, you know, we can't look after the patients. As a nurse, I always came into nursing very much putting the patient first and being very patient focused. But I've learned actually since then that actually, not that I'm not patient focused, because clearly I am, but taking a step back before that, actually, I probably underestimated how important it is to actually look after each other, look after our colleagues, because if we don't do that, then we've got no workforce. We've got to look after each other as people before we even get to patients. And we can see that in terms of the burnout. We can see that in terms of retention and recruitment, sickness levels in the NHS. We've got to look after each other better. Next slide, thank you. And this again, I think, just demonstrates some of that. So again, some of you are probably already aware of the Civility Saves Lives campaign. And if you're not, again, go and look it up because it's a fantastic campaign, really just promoting what I've been talking about. It's really close to my heart because Chris Turner, I actually worked with at Midstaffs. He was one of the good guys. He was one of the doctors in A&E who supported me. And he's now the clinical lead at Coventry and Warwickshire A&E department. And he does a lot of work on, he does TED Talks and all sorts of things. So Google him, look him up. He's fantastic if you haven't seen him before. Again, this is just a snapshot of some of the stats out there, but this just horrifies me. So if you think about what we do as clinicians, we're out there really looking after patients, aren't we? And for somebody who's just rude to you, now we're not talking bullying, we're not talking about abuse, we're talking about just somebody just being rude to you, and particularly if it's a pattern of behaviour. So it's not just a one-off if it's something that happens quite frequently, but even if it's just a one-off, they found that in various studies, and a lot of these studies were done in the States, I think, but they found that there's a 61% reduction in cognitive ability, immediate. So if somebody's rude to you and then you're going in to treat a patient or to do whatever you're doing, that, you know, think of the impact of that. For people who've just witnessed it, for bystanders, there's a 20% reduction and they're 30% less likely to help others. So this is how the negative culture starts to build and pervade. Patients and relatives who may see this, and again, as I said at Midstaffs, they certainly heard it and witnessed it some of the time. There's a 73% reduction in net promoters of the organisation and their own personal experience. And obviously, as a team, there are reduced cognitive ability, capacity, and ultimately worse outcomes for everybody involved, which again, when you think about what we do, that can be catastrophic. So it's really important that we're just nice to each other. You know, everybody can have a bad day and we can all, you know, speak rudely to each other sometimes, but we have to have some self-awareness and we have to have some insight, and we have to go back to people. If we have done that, apologise and you know, make sure that it doesn't become a pattern of behaviour. Next slide, thanks, Nadia. So these are the last couple of slides, because I'm sure there's questions, and I hope it's been useful, and I don't want to go on, said to Nadia earlier, I don't want to do death by PowerPoint, particularly at this time in the evening. But these are some of the questions, again, I think that when we're leading the way on challenging the status quo, some of the things that we need to look at. So these are just questions that you can ask yourself or encourage colleagues to ask when you're thinking about making the changes, or whether you think there are concerns that need to be raised. You know, what needs to be changed? What can be improved? Not that you have to have those answers necessarily. I mean, I hate the thing where people say, don't bring me problems, bring me solutions. I hate that, because I think that pushes people away from speaking up and raising a question. But equally, I would argue that in the most part, those on the front line, those doing the job day in, day out, actually do have the solution. They do know what needs to be changed, and they've probably got a really good idea of how to do it, but actually they're not asked, they're not genuinely consulted or encouraged to be part of the resolution. And I think that's a really important thing that, again, we're missing. And again, that's something we need to lead the way on. And again, taps into the fact that we need to be asking students and newly qualified their opinion to be around those tables and discuss when things need to be improved. What's the greatest risk professionally, personally? What are the risks to patients? What are the risks to each other? What can you expect? What are your expectations in terms of raising issues, raising concerns, being realistic about what that might be and what that might look like? And crucially, what can we learn? Because I think the biggest thing for me about raising concerns, it's never about getting people into trouble necessarily. It's not about a punitive thing. I really hope it's about learning and improving things for patients, improving patient care, patient safety, experiences for our colleagues as well. But it really should always be about learning and improving, and we've got to start with ourselves with that. So asking ourselves, each other, you know, where can I make the change? What can I do to change it? I think that's really important. Next slide, thanks. And this is the final one, thanks guys. I have to end on a quote from Florence. And I think although here she's talking about patients, clearly, for me, this resonates really with colleagues and the workforce who may have been brave enough to come forward and raise a concern, or they're thinking about doing it. And that apprehension, you know, is really scary. And, you know, we have to understand that, and we have to look, you know, beyond that. And as leaders, all of us, particularly if you're in a designated leadership role, but even if you're not, all of us need to lead the way, and we all need to ask ourselves, you know, how can I always do the right thing? How can I encourage each other to do the right thing? But how can I enable it to be done? I think is what she's saying here. And clearly she's talking about enabling it and providing for patients, but I would argue that we need to provide that for each other to then be able to provide it for our patients and make a safer NHS and a more sustainable NHS and social care going forwards. Thank you guys for listening. Hopefully that's been useful. I know we're short on time now, but are there any questions?
Helené, thank you so much. Kind of just a bit taken aback. I think initially with your background story, I'd heard about everything that had happened and read about it, but actually hearing it from you is shocking. Actually, I think that, you know, I don't think it's anything more to say than I feel really shocked, and I'm incredibly grateful that you had the kind of stamina to continue. And that was the thing that really got me, was how you continue through everything, through all the setbacks, that you managed, you continued and you pushed for what you thought was absolutely right, and of course it was right. I've got a couple of questions in the chat. I'm just going to read them out to you.
Yeah.
I've got one from Rachel, who's asking kind of a practical question about whether freedom to speak up is a requirement for private and non-NHS organisations.
Yeah, it's starting to be. It's not a requirement by any stretch, but it's starting to spread into those organisations. So we've now got them, we've got them in ambulance services, which we've had for a while. We're getting them in care homes, in hospices and so on, which again is a really worrying kind of closed environment. So it's really great that they're spreading into there. Into primary care, we've got a lot of pilots out there at the moment where we've got GP practices who are either sharing guardians with a local trust or a sort of through a sort of group of practices. So it's beginning to develop. It's not a requirement, but it's absolutely gathering pace and momentum, as it is in the devolved nations. So it is a requirement in England, not necessarily in devolved nations, but a lot of following. So I know we're doing a lot with, particularly with Wales and Scotland at the moment, to spread it across those. So it's definitely gathering pace, as it is in other industries as well. So I've spoken to the police, to teaching, to the military as well, and they're got quite a lot of interest in it as well. So I think it is going to be something that spreads and spreads.
Thank you. Vara, you had a question. You had your hand up. I don't know if it was an accident or you just taken it down, but if you want to speak, put your hand back up and I can allow you to talk. Gonna hope she's...
Yeah, can you hear me?
Yeah.
Yeah, I mean, you kind of answered part of my question there. I'm in Scotland, so I'm a newly qualified midwife in Scotland.
Yeah.
And it works slightly different in Scotland. With the NHS, we have boards rather than trusts. The board which I work in 2019, there was an independent review into allegations of bullying and harassment, which is quite difficult reading when you read it, but as somebody who trained in this board as well, it is things that I experienced as well. So I guess my question was kind of, when you don't have the guardians to kind of turn to, what would be your recommendations? Where would you recommend that people go for support? I think it's fantastic that it sounds like we are going to get them here as well, which is great. But what would your kind of advice be for people in the devolved nations?
Yeah, so hopefully it's coming, hopefully. But even in spite of that, there are always things you can do. So obviously the unions, although I left this bit out of my story a little bit, but again, because I've been here all night. I'm a member of the RCN. I still am. I've still kept the faith, and I work really well with them now. But my RCN rep let me down because he represented me at the same time of representing the two nurses I spoke of, and didn't declare that. And then, as I said earlier, he struck the deal with the NHS to bring these two back in without a conclusion to the formal and independent investigation. So there was huge questions, and that was discussed at the public inquiry, and I've worked really closely with the RCN now, and they're very different. I also, in my role, work really closely with all of the unions. I meet regularly with the chair of the staff side, and so on, and I work kind of hand in hand with them, and we share soft intelligence and triangulate information. So they're a great resource. So I'd always tell somebody to certainly get a union and go to them in the first instance if you've got concerns, even if it's just a bit of advice. So unions are obviously out there. Obviously going back to our regulators as well. So again, I've worked with the NMC a lot in terms of raising awareness, and I still do, around speaking up. So obviously the NMC is my regulator, but for whichever profession it is, the regulators should be there to help support you if you've got significant concerns and help signpost you. And so I think, they have a responsibility to help support people in these situations, even if it's just advice and support. The other place as well, it used to be known as Public Concern at Work. It's now called Protect, which is a whistleblowing charity essentially. But they do fantastic work. And again, I'm affiliated with them and do a lot of work with them. Again, complete confidential, you can ring them up, and they have a lot of lawyers as well working for them who can give excellent advice. And again, they work across all industries and sectors, not just health, but they're a fantastic resource as well. If people are really concerned about something and they're afraid of speaking up, they can give some really great practical advice on how to do it. So those are sort of the top three places I would go for advice and support.
Thank you. We've got one more person with a hand up, Lee, who I'm going to go to in 1 second. I just want to give you some feedback from one of our students who said, I find being what I call constructively disruptive, I can be seen as a troublemaker and a pessimist or a negative person. But I find that as a reality, it's a reality. And as I say, being constructively disruptive, we need more of this. And it's so hard being a student and as well being a newly qualified nurse as well. But yeah, we need that, call it out when it's needed.
I do, and the whole thing, the troublemaker tagline, I so get you with that, and I hear it so often, and people saying, I'm not trying to be a troublemaker, but it's just awful. But again, it's just something we just have to keep pushing against, really, and it is changing. Believe me, in my time, although I'm still seeing these negative things, it is decreasing, or even if it's not decreasing, it's being called out more. It genuinely is. There's more transparency to it. We're having these sort of discussions a lot more. It's being heard at a higher level, when it was just completely dismissed before, or just seen as, well, that's it, that's how it's always been, or people just moaning and groaning, get on with it. So it is beginning to change, but we're still in the early stages, sadly.
Lee, do you want to unmute yourself? Oh, sorry, I think I pressed mute on you.
So first off, I want to say thank you for your talk tonight. It was really inspirational and really helpful.
Thank you.
I really just want to ask, within the health board of training, I train up here in Scotland as well. I often find that the health board that I train in, even though my uni is the only health board within, it's the only university within that health board, so there's often a lot of continuity within the education and the mentors, and understand what the uni expects. So there's a lot of continuity with understanding what we as students go through. I do often find with my university though that raising concerns about certain things in practice can be difficult, and it's just supporting how as students we can raise concerns constructively with our universities, and go forward with that in a positive way. Because as a student, I've been through quite a negative action plan process in the past, and it felt as if there was bullying from my mentor. And even though like the PEFs are there for support for the mentors, and I completely appreciate that, whereas the uni are there to support me, I felt in my situation that time the university were not supporting me as a student the way I should. And the member of the practice team who came out didn't, it was a person I was very unfamiliar with, but didn't know anything about me really. I appreciate that, there's a whole practice team there to support every student, but not everyone's available. But I felt there wasn't any continuity with people who knew the student. And I felt that when I raised concerns about my mentor at the time, the university just dismissed it and didn't care about it. Like things like what you were saying tonight about misstaffs, it there were a lot of parallel themes they just kind of brushed under the carpet. So I think ultimately it's how can we as students, raise these concerns and, make sure we're supported by our universities who are there to support us. And if there are those concerns, who can we turn to?
Yeah, I think it's really difficult because you're in Scotland, you don't have the guardian role. It's difficult because normally I would say in those sorts of circumstances, you could go to the guardian affiliated with the trust. However, I would like, and this was going to be my kind of take-home message for you all really, is to maybe go back, certainly for those of you who are still students, maybe go back to your universities and have a question, have a dialogue with your universities about even creating a guardian role within the university. And there's nothing to stop you doing it. And I'm sure if you get in touch with the National Guardian Office and get in touch with me, I'll help you do it. Because I think there is a need, not just within the trusts or the boards in Scotland, but certainly within the universities as well. So we often know that people will not raise a concern whilst they're still on placement. They'll wait until they finish their placement and then raise it. So that you're going back into university, you're not on placement. And we often know that a lot of the response you get from your university tutor or whoever is, oh, well, you finished there now, so don't worry. But that doesn't help the next person going in. And it certainly doesn't help if it's an issue around patient safety or patient quality of care. So there is more universities should do. And this is, again, partly why I wanted to come and talk to you guys, because, again, you can help make the change. You can help raise the question, is there a role for something like a guardian who will sit within the university? Now, I know you have student representatives and kind of welfare officers and all of that kind of thing. So it might be kind of an amalgamation of all of that, or assigned to somebody who sits within that. So that's something that you can do. I think the other thing is, if you are getting pushback from whoever you're going to within a university and you don't feel they're listening, then again, you as a student, I clearly always recommend that you join a union as well. And you can go to the union and say, I don't feel like I'm being supported in raising this, not necessarily within the trust or the board, but within the university itself. And the universities have to step up and get, aligned to this as well. And many of them are already. But, again, you just have to quote mid-staffs and they should sit up and listen. And if they don't, that's scary and worrying in itself. So it's difficult because you don't have the guardian role up there at the moment, but it doesn't, I'm hoping it is coming. But it is something I think you can keep pushing and raising issues along. And again, there should be support from unions with regard to kind of well-being and support as well, because it has a really negative impact on you. I think more so as a student and even when you're qualified, because it's a really difficult thing for anybody to do, but particularly as a student. So I think there is something that universities need to do more on in terms of the welfare of that student, but also really pushing this agenda. And again, challenging the status quo. It might have always been that that's the way it was dealt with before, but actually we need to change it now. You know, things are moving on and they need to get with the programme. So there is a lot of support there, and although you're in Scotland, it doesn't stop you seeking advice from the National Guardian Office down here, and we can help support and offer some advice. But again, seeking support from unions, I think, is really important, and you know, like I say, you know, make the change yourself as well if you can. And I know you've got a million other things to do, so maybe it's a bridge too far, but if it's something that you'd be interested in, I'm sure we can offer support. And I would recommend all of you to go away and have some conversations with your universities and say, look, is this something we can create? And maybe you are the guys to do it. So just food for thought.
Helené, thank you so much. I feel really privileged to be able to hear you tonight, and I know there have been lots of comments saying similar, and I hope that has given people some inspiration to take action where it's needed, and also to just kind of, you know, remember what the focus is, and patients are at the focus and the heart of what you're doing, but also, you know, yourselves as well, being kind to other people, which I think is a theme that we've been hearing a lot about over the last 10 months. But Helené, thank you so much for your time this evening.
Thank you.
I'm really grateful to be speaking with you, and I'm really grateful that the technology held up after.
Yeah, I know. I'm sorry about that blip earlier, but at least it was only momentary. So thank you for listening, everybody, and apologies we've gone over a little bit. I could tell the story, as I say, all night long, and it's really difficult to try and condense it into one. But again, I'm sure if there are any other questions, then I'm sure Nadia will help signpost you to me or whatever. And I've said to Nadia as well, I'm happy to come back at a later date if it's something that would be useful in the future. So don't hesitate to get in touch if that would be helpful.
Thank you so much, Helené, and everybody. Thank you and good night.
Thank you, everyone. Night.